Hello and welcome. I'm Dr. Gary Howsam, a GP in the East of England and the Vice Chair of External Affairs at the Royal College of General Practitioners. First of all, Happy New Year and welcome back to those of you that have joined us for one of our #RCGP live events before, and a particular welcome to those of you who are here for the first time. You can put your questions to the panel this evening through #RCGP live on social media, or by entering underneath the YouTube feed. We've got members of our team that will be looking out for your questions there. Thank you for those who've contributed already through the Instagram polls and the other social media polls that we've been running during the course of the day. If you haven't watched one of these before, these sessions are about letting you know what the RCGP has been doing on your behalf as our members, for you and for our patients, to make sure we keep everybody up to date with the issues on the ground and some of the lobbying and action that goes on behind the scenes. We've got a broad wealth of experience on the panel tonight, and we'll get those people to introduce themselves to you shortly. We've got a whole host of COVID resources, including resources around COVID vaccination on the RCGP website, and I'd encourage anybody to go there to have a look at those after the event. And we'll also be posting through social media channels anything of particular note that's mentioned during the course of the discussions. So we find ourselves back in another national lockdown with soaring rates of infection, increased number of hospitalizations and death. But there is a glimmer of hope. And as we enter the new year and the vaccines have come online from both Pfizer and more recently from Oxford and AstraZeneca, it's vitally important that we get the vaccination rolled out as quickly as we can across the population of the UK in order to allow us to go back to some normal sorts of life as we used to know it. One of the advantages of being a membership organisation and with our 54,000 members on the ground is that we get to hear the frustrations and the challenges you're facing on a daily basis. And we'll talk about some of those during the course of this evening. And we can also tell you how we reflect those up to the powers that be that really do need to hear from the front line the challenges that we're all facing in delivering the vaccine. The vaccination and the delivery process is a real team effort. We know that in general practice, that without our nursing colleagues, our pharmacy colleagues and the others that we work with on a daily basis, that we simply cannot achieve the aims and best care for our patients. So we've got members on the panel from a nursing background, pharmacy background, and a number of practicing GPs who also have other roles in specialist organisations that will be contributing to the discussions this evening. Inevitably, when we have these discussions, they sometimes turn into a bit of an acronym soup. So what I'll do to start off with is try and explain what some of those acronyms mean and just quickly describe the process of when a vaccine comes on board in the UK. Once a vaccine's been developed, it's regulated and approved by the MHRA. The epidemiology and use is reviewed by the JCVI. NHSE will look at the logistics of delivery with the Department of Health and Social Care, and PHE provide the Green Book chapter, which tells medical professionals the latest guidance and procedures. The BMA negotiate the contract for delivery on behalf of GPs too. So with all that in mind, let's get on with our discussion. As I mentioned beforehand, we're back into a national lockdown. And although we've made a great start on rolling the vaccine out with 1.3 vaccinations done already, we've been given an important target of about 13.9 million people to be vaccinated by the middle of February. So the first question I'd like to direct towards Martin Marshall, Chair of the College, is Martin, why should GPs be at the heart of the solution? And as I said before, if you could just introduce yourselves as you speak for the first time, please. Thank you.
Yeah, Gary, thank you very much indeed, and welcome to everybody. Thank you so much for joining this webinar. I hope it's going to be fun and I hope it's going to be informative and useful to you. So I'm Martin Marshall, I'm Chair of the College and I'm a GP in Newham in East London and also an academic at UCL. So Gary, yeah, a spot on question. Why should general practice play an important role here? I think the answer is quite simple in many ways. If you want a job done properly, ask someone who's done it before and ask someone who's got a track record of delivery. And I don't want to be too cheap here, but that wasn't what happened with test and trace. And we saw the consequences of it. It is what's happening with the vaccine, and we're seeing, even in the first few weeks, an amazing capacity to deliver at pace. General practice is really important. There's three basic delivery systems. There's the primary care-based general practice, there's a hospital vaccination units, and there's the mass vaccination centres, which will be established over the next few weeks. my view is that general practice is going to play a really fundamentally important part in that process. The reasons for that is we serve our communities, our patients trust us, they're used to coming to us to receive their flu vaccination. Trust is really important, particularly for a new vaccine like this, and particularly our access to the more vulnerable members of our community. So for all those reasons, I think it's really fundamentally important that general practice plays a massive role. I don't say that lightly. The college more than anybody understands the enormous pressures that general practice is under, trying to deliver business as usual, trying to deliver the expanded flu vaccination program, and now trying to deliver COVID. But this is such an important thing for our community, such an important thing for our country, that I'm not surprised, and I'm really pleased to see that general practices around the country are stepping up and wanting to do it.
Thank you, Martin. We've heard from the Prime Minister, and we've heard indeed across the political spectrum, that we've got a target of about 2 million vaccinations a week in order to get through the top 4 priority groups by the middle of February. So I'd like to go now to Anthony Harnden and ask you, Anthony, to introduce yourself. And perhaps you could tell us, do you think that target is realistic?
Thanks, Gary, and thanks for inviting me today. It's a pleasure to be on. My name's Anthony Harnden. I'm Deputy Chair of the Joint Committee on Vaccination and Immunisation, a working GP in Wheatley in Oxfordshire and an academic at University of Oxford. Can we achieve the 2 million a week? Well, I feel positive, like Martin, that general practice is up for this. We deliver 15 million influenza immunisations per year as in general practice. It's a real team effort. We have great multidisciplinary teams. We have very enthusiastic GPs and very competent. We have the best infrastructure in the world for doing this. And I think if anybody can step up to it, primary care can. 2 million a week is challenging, but when I extrapolate it in my own practice, we did 1,000 immunisations for our network over New Year's Eve and New Year's Day, and we're going to be doing another 1,000 this weekend. Now, if we multiply that around the country, the number of practices, we have 7,000 practices, 8,000 patients per average in practice. Yes, it can be done. I mean, the figures work. We could actually deliver this in primary care without any help, but we are going to have help because we're going to have hospital-based systems. As Martin says, we're going to have mass immunisation centres. We're going to have other professional groups, which we'll hear about later on. So I feel very optimistic and positive, and I think the really important thing is that we look after our workforce. We don't get vaccinator fatigue, and we're very careful and clear with how we manage and look after our primary care colleagues. So yes, thank you all for participating in the programme in advance.
That's great. Thank you ever so much, Anthony. We've got a number of members of the primary care team here. I think the last figures I saw out from PHE were suggesting that with regards to the flu vaccination in general practice this year, we've already seen a 77% uptake in patients over 65, which is approximately 9% more than this time last year. Now, I know as a frontline GP myself that it's not GPs doing all of this. In fact, the vast majority of it is being done by nursing colleagues and pharmacy colleagues working both within the practice and within the community. So I'd like to go next, please, to Helen Donovan. And Helen, if you could introduce yourself, please, and tell us the role of the people you represent in this really important programme.
Thanks very much, Gary, and thank you for inviting me on the panel. So I'm Helen Donovan. I'm the professional lead for public health nursing at the Royal College of Nursing, and I'm a nurse with an expertise and special interest in vaccination. So I would also say to colleagues that there's a lot of resources that the RCN have published around the COVID vaccine programme. And I would absolutely agree. I think nursing teams are absolutely fundamental and, dare I say, crucial to the delivery of all vaccine programmes, and will and are being fundamental to this delivery as well. And I think that it's absolutely essential that we use that multidisciplinary team approach in order to get the vaccine out, because not only do we need the staff, but we need that sort of all-rounded expertise. And as I think Martin said, it's about engaging that public trust and being able to talk to people and being able to explain to people. And I think that's something that nursing colleagues do all the time and absolutely fundamentally. It's inevitable. We've seen already, changes to the way the vaccine program is being delivered. And I think, inevitably people need to be able to keep up to date. So from a nursing perspective, I'm very proud and honoured to represent the nursing profession here. But also to sort of celebrate the role that they have in delivering of this programme.
Excellent. Thank you very much, Helen. And perhaps, Ravi, I can come over to you for a comment from a pharmacist colleague, please.
Yeah, cheers. Thanks for this evening. Ravi Sharma, Director of England at the Royal Pharmaceutical Society. If I were to say general practice staff play a fundamental role in the delivery of this vaccination programme, that would extend wholeheartedly to my pharmacy colleagues working across general practice and primary care networks. This is the pharmacists, pharmacy technicians, the clinical commissioning group colleagues who are helping with operationalisation of the vaccination, and probably extending to my hospital pharmacy colleagues who are also supporting mass vaccination sites. I think it goes without saying that those colleagues working in general practice are skilled, trained healthcare professionals and vaccinators and have an absolute role in supporting, supervising and administrating COVID vaccinations, and have demonstrated this throughout their careers through supporting delivery of a, for instance, flu vaccination programme. When we're talking about primary care more broadly, I think it's really important to mention the fantastic role of collaboration between general practice and community pharmacy colleagues, particularly around stuff like the flu vaccination. I think both services are up on last year's numbers to date. And what is really hopeful is that the community pharmacy colleagues with the AstraZeneca and Oxford vaccination can also play a leading part in helping deliver a mass vaccination programme and upscaling the targets of 13 to 14 million vaccinations by middle of February by including them in that wholehearted effort. And so just to say that it's a real team effort, utilising the skills across the primary care workforce is really, really important and will be fundamental to delivering those numbers for now and the future.
Okay, thank you, Ravi. And I'd like now to go across to Mark, who's the last member of our panel. And Mark, I think you're a practicing GP yourself, and you've got a role with the BMA. And I think, obviously, I said in the introduction, the BMA is involved in organising the contract. And that tells us that this is additional work for general practice. So this is more on the plate of an already very, very busy profession. So have you got any views around how we have to be careful that we don't get so distracted by this that we leave gaps elsewhere?
Yes, thank you, Gary. So I'm Mark Sanford-Wood. I'm a GP in Plymouth. One of my hats is that I'm the clinical director of my local primary care network, and I'm also deputy chair of the GP committee at the BMA. So as people have already said, GPs and our teams, our wider teams, are the experts in mass vaccination, and this is our time. Teams around the country are saying to us, and teams are saying locally to me, that they're really up for this. Patients trust us, and we're the right people to do it. But it will be a challenge. At the moment, general practice is the only sector in the NHS that's now performing back at 100% of volume compared to before the pandemic. There's huge backlog in the system. There are enormous pressures, and now, of course, we're in a new lockdown. But this is doable as long as we have the right support from the rest of the system. Locally, we're getting a lot of support from our CCG, but at a national level, I think we do need to make sure that we get the balance right, so that we don't put all of our eggs into either the vaccination basket or the business as usual basket. We have continued to talk to NHS England around income protection and a resurrection of the COVID fund. We are in discussions about wider QOF suspension so that people can focus on acute medicine and acute need and long-term conditions as are required clinically. We need to look at things like the progression of QI modules. We've already looked at appraisals, and appraisals were originally suspended. They were reintroduced, but there is a lot of flexibility around appraisals now. And obviously, we've also approached CQC who are again stepping down a lot of their routine regulatory business. I think there's lots of other bureaucratic elements that that we've been dealing with, things such as the Department of Work and Pensions, the wider process around death verification and certification, all of those things that we introduced back in April and May, in conjunction with the college. They're still there and they need to continue. And finally, I think something that's already been mentioned, but I really need to make this point very strongly, that we do need to slim down the requirements, and we need to streamline the process for that workforce that is out there who want to return, those retired nurses and GPs who want to come back and be our vaccinating, they want to be our vaccinators, and we really need to facilitate that at every opportunity. So I think if we do all of that, then we can get the balance right. We can deliver this. It is deliverable. It will be a huge effort, but we do need the support of everybody else in the system.
Brilliant. Thank you for that, Mark. And I think that that's a really important message. There's lots of people thinking about the balance between the things that we need to be delivering here. What's interesting is we did an Instagram poll during the course of today, asking our members, did they think that the 2 million per week vaccination target was realistic? And looking at the numbers, it was only a third of them that said they did. 67% saying no. Now, that usually suggests if there's a lack of confidence there, perhaps it's a deficit of communication, or that they're facing challenges on the ground. And as we've said, one of the benefits of being such a large membership organisation is that we do hear about those challenges. Now, I know Mark, Anthony and Martin have all been involved in giving the vaccination. So perhaps I can go to you first, Martin, just to hear about some of the challenges that have been reflected back to you, either at a very local level with your PCN or in your role at the college.
Yeah, so I did my training and was involved in the delivery of the first group of Pfizer vaccines that were available in general practice. What was it, about 3 weeks ago now, I guess. Feels like forever ago. As a practice, we were at the time we were the one practice serving the whole of the borough of Newham in East London. I think there was an awful lot of planning that went on between the practices involved, with the help of the CCG and the help of our CSU as well. Did we get everything right straight away? No, I don't think we did. I think in the first day we probably delivered around about 250 or so vaccines. We didn't necessarily have our flow right. EMIS kept collapsing, which caused a few practical problems with registration. And then we were in the very early days of Pinnacle, when Pinnacle also went down for the first hour or so of vaccination. But we learned a lot. And by the second day, we were much faster. And by the third day, we were faster again. We had no problems at all getting through our 975 vaccines. And we did what general practice does really well. We basically learned on the hoof. And I think that's what all practices have been doing, and PCNs have been doing. Are we still hearing about problems now? Yes, we are. And I know what a deep frustration this is. We're hearing about practices that have volunteered, who've been told that supplies are arriving whenever, 2 days' time, and sometimes at short notice have been told that their supplies are no longer available and they've had to cancel their patients or postpone their patients for another time. And we hear of a larger group of practices who have volunteered and want to be part of the system, but haven't yet been asked and don't know when they will be asked. Now, I think we have to be a little bit gentle on this. You know, this is early days for a massively ambitious program. As a country, actually, I don't want to play the European game, but actually we are doing pretty well in comparison with other countries, and that's a consequence of having a really good infrastructure. And I think we should be proud of ourselves, and we should accept that we're not going to get everything right straight away, but we are learning. I mean, of course, as a college, we're always going to be asking, I'm sure the BMA too, are always going to be asking for a higher level of efficiency and competence from the people that are delivering the vaccine to our practices, of course, and that's what they want as well. It's going to take us a little time. But overall, my sense is that we're in a pretty good place, and we are gearing ourselves up to be able to deliver the 2 million vaccines a week, which is going to be necessary to hit the targets.
Brilliant. Thank you, Martin. Anthony, you mentioned that you were vaccinating across New Year's Eve and New Year's Day, which I think shows the dedication of the primary care teams that are out there on the ground. What sort of challenges did you face?
Well, I mean, there were lots of logistic challenges because, of course, this was a very elderly population that we started with. And so the challenges of getting them directed to the car park from other practices. Of course, many patients weren't familiar with our car parking, right the way through the flow into the building, to the mixing of the vaccines. We had a pharmacist who was fantastic, actually, who helped with the mixing of the vaccines, together with a couple of retired colleagues. And then, of course, we had similar problems to Martin, really, with some of the IT issues. We actually entered it onto EMIS and then decided at a later date to put it onto Pinnacle, whereas next time round, I think we're going to put it directly onto the data directly onto Pinnacle. One thing that was really good, actually, was that we managed to get 6 doses out of these Pfizer vials when we were expecting only to get 5 doses and 6 out of some, but we got 6 unanimously unanimously, we got them out of all of them virtually. And what we were able to do, which was really quite impressive, was to call a number of patients up at very short notice in those priority groups and get them in for those spare vaccines. So we didn't actually waste 1 dose of vaccine. And I think that was really down to our pharmacist colleague, who was absolutely fantastic and was able to sort of supervise that. The nurses were brilliant, I must say. Our nurses really, really stepped up to the task. So yeah, it was difficult, and I think we'll do it slightly differently. I mean, I think one of the real difficulties with this particular Pfizer vaccine is that having to hang around in the waiting room for 15 minutes afterwards. And I think once we get the AstraZeneca vaccine, and if the MHRA take a slightly less vigorous view to the waiting time, I think that will ease the pressure, really, because I think, we still got COVID and we don't want to give people COVID by coming up for the vaccination. So we still have to do all the social distancing and the masking and things. And I think if we can get rid of that 15-minute wait time, I think that will ease things. So I agree with Martin. I mean, there's huge challenges and it's bound to be bumpy at the start. But I think with a sort of can-do approach, which certainly my team took, all of them actually, quite dedicated, really, really good team working right across the disciplines. I think primary care can really step up to this.
Excellent, thank you, Anthony. And I mean, that seems to be a very common story that we're hearing. Certainly, one of my roles, I'm a CCG chair, and the PCNs that went live first in our footprint started slow, but learned an awful lot very quickly and have managed to scale up and are now delivering at a much higher level. And I think if you can imagine multiplying that across the multiple sites as they come online as well, we really are looking as if we could be hitting that 2 million really quite quickly. I'd like to bring Helen in now, if I may. So Helen, over to you.
Thanks, Gary. Yeah, I mean, I would just echo that. And I think one of the things that primary care is able to do is be, what we call, responsive and agile to things, but also to be able to respond to what's available in a local area. And the planning has been really intensive, and there's great plans in place and everything else. But it's inevitable, as I think both Martin and Anthony have said, is that these things will change as we move through the program. And I think with all vaccine programs, actually, we've had, there's a rocky start in a way in terms of how we roll it out and how vaccines become available and getting to grips with the guidance and getting to grips with the advice and information. And so it's absolutely inevitable. But I think primary care, nurses, GPs, pharmacists are absolutely able to do that. And my experience is that you develop things at a local level and obviously share that. So what will work in Lewisham, say, and parts of London won't necessarily work in other parts of the country, but you develop that based on what you can do. And I think that's the other really sort of good thing about primary care, is that we can do that and we can actually manage that process. So it was really just to echo that. And I think, you know, what I'm saying to nurse members as well is that because it's a new programme, it's absolutely essential that people sort of recognise the early days. And I think, you know, with 1.3 million doses already in the time that we've had is absolutely phenomenal, and that number will increase. So whilst I can appreciate that RCGP members and RCM members are sceptical that we're going to be able to achieve the numbers that we need to by mid-February, I think what colleagues are saying is that they are able to ramp it up because they learn as they go along. So I you know, I'm an optimist at heart, but I do think that we've got a good grounding to do this.
Excellent. Thank you, Helen. And I agree entirely. And I think it's really important that whilst we are highlighting some of the challenges, that we really do celebrate the fact that we've got, you know, 1.3 million people vaccinated already, because that's really important. I think one of the other challenges we faced was when we had the change in guidance around the second dose and the logistical challenges and things that provided. Mark, do you want to comment on that at all?
Yes, thanks, Gary. I mean, you know, really, we've done an amazing job already, 1.3 million doses, but we also need to bear in mind that the target is going to be somewhere around about the 100 million mark. So if this were a 3-course meal, we'd have just finished off the first mouthful of our starter. So, you know, we need to keep that in mind. But it's been an astonishing effort so far. In my PCN, we've already vaccinated 3,500 of our very most vulnerable patients. You know, and that's down to the amazing work of our nurses, our pharmacists, our practice managers. And I think that's a group that really needs to be recognised in this work as well. And of course, our admin teams. I think your original question was around some of the problems that we've experienced, and certainly I think Martin mentioned about the problem with supplies and delivery dates, and some delivery dates slipping, and that can be extremely difficult when you're having to stand up teams to do this. But I think one of the challenges that we've had obviously has been around the protocols. And some of the timing of the doses. That has operationally been quite a challenge for us. We recognise the reasons why that advice has changed. You know, and our national regulators are trying to provide the greatest level of coverage to the greatest number of people. But that did have real operational challenges for PCNs such as my own, actually, that were due to be giving second doses of Pfizer vaccine this week. And in many cases, I think that really was close to impossible. So it has been very encouraging today to hear an understanding of that position from the Minister. I think there's also, Martin mentioned about the issues around Pinnacle. And we've had plenty of reports where Pinnacle has suspended or crashed in some sites for a time, and that's been a challenge. And there's also still the issue between the link between Pinnacle and EMIS, which we're working hard to sort out. I think our teams have found that the really hard bit of this has been booking people in, phoning around, having those conversations, particularly with people who may be hard of hearing and who may take some time to gather their thoughts and get themselves organised. That will get easier as IT solutions become more viable in more IT literate groups. But you know, I think we have to recognise that we would have spent at least 6 months in normal times sorting out and planning for a campaign of this size. At the very least 6 months. We would certainly have spent 6 months negotiating the contract and getting it just right. And we've done this in the space of a week or two. It's a very complex system. There are many moving parts, and they're not always going to work absolutely correctly right from day one. But the real test of this is going to be how people respond, how they rise to those challenges. And I have absolute confidence that general practice can do this.
Brilliant. Thank you, Mark. Could I just ask you very briefly to explain what Pinnacle is? Because there might be some people listening tonight. They'll probably know that EMIS is one of our clinical systems. Just very briefly, what Pinnacle is, please.
Yeah, so Pinnacle is a piece of software. It's a web-based software, and it was, I believe, Ravi may be able to explain a bit more about it, but I believe its DNA came from farm outcomes, and it's a system that community pharmacists use to record their activity, and it is also a payment mechanism for them. The reason that it was necessary for us to use Pinnacle, which is something that GPs haven't done before, is because I think it was acknowledged that it's the only national platform that runs right the way across all the different sectors that can be accessible by different people. So if someone goes and has a vaccination in a hospital, they can record it on Pinnacle. Somebody in a community vaccination centre can see in real time that vaccination has already been given. So it will prevent doubling up of vaccinations, which clearly would be a major issue. So that was the reason why Pinnacle was introduced in this context. There's a lot of very rapid work being done to make sure that Pinnacle integrates with the major GP IT systems. The one system that at the moment is still something of a challenge is the link into EMIS, but that is being worked on very rapidly, and we are assured that that is a solution that will be ready to go very, very soon. I mean, within the next few days is the feedback that we've been told, and so that's what Pinnacle is. That's why it's being used, and that's why it was a little bit of a challenge, a bit of a novelty for our admin teams to get used to that. But actually, once you start using it, it's a very simple system and pretty intuitive.
Excellent. Thank you very much for that. So I think, looking at this from a national perspective, we've got a problem and we're trying to find a solution, and we've got different groups of people looking through it, both a scientific lens, a political lens, a professional lens, logistics. So we've got lots of different viewpoints coming in here, and we're not going to agree on everything. Martin, could you just tell us a little bit about the role that the college has been playing on behalf of its members? We've heard concerns around supply chain, concerns around workforce, concerns around the dosing. What role has the college been playing behind the scenes as well as publicly in order to iron out some of these issues?
Yeah, thanks, Gary. So responding to COVID has been our top priority as a college for nearly a year now, and clearly getting the vaccine right is our top priority now. So an awful lot of our resources and effort across the college is focused on getting it right. Some of that is around understanding the science and the logistics. We have regular meetings as a college with the CMO and with NHS England and with the Secretary of State and ministers. So we understand what's going on, we understand what's going on in their head, and we talk to them and encourage them and persuade them. For example, in the early days, actually, they did need persuading that general practice has an important role here, but we've succeeded in doing that, which has been great. So a lot of it is around kind of political positioning and understanding. Now it's mostly about the practicalities. And we've been having a range of different conversations, some around the practicalities of delivery that we've been talking about, some around the practicalities of things like the delayed second dose. And I think, Anthony would probably be a good person to respond to that first, but then, maybe others of us on the call can jump in with our perspective on that. So that's been important as well. Probably one of the biggest challenges for us as a college has been about the workforce, and we've started talking about this. Right now, there are enough vaccinators to deliver what general practice is delivering. That won't be the case in 2 or 3 weeks' time when more supplies are on board and we're delivering at 2 million a week, let's hope. We will need a larger workforce in order to do that. And as a college, I hope people have noticed over the last few days in particular, we've been lobbying very hard around the returners, the early retirees workforce. So the reason for that is these are a group of experienced clinicians, not just GPs, certainly nurses, certainly pharmacists, physicians, surgeons, a whole range of people who for 30 or 40 years have been wielding needles, who know how to do it, who've got all the necessary skills to do it. And at the moment, they're being put off. They're willing, they want to come back and do something. They're being put off by the bureaucracy. So we've been working very hard over recent days, lobbying hard. And I have to say, hopefully successfully from what I can see. So it looks as if we've got a much lighter touch approach to allow people to come in. Because if you want to be a good vaccinator, just a vaccinator, we're not asking for a broader role than that. You've got to do your probably hour and a half, 2 hours training on understanding how to vaccinate and understanding the principles of the vaccination. You've got to be able to deal with anaphylaxis and provide basic life support. You've got to have signed a contract so that you have indemnity, and you've got to have been vaccinated. And probably actually that's, others might disagree with me, but I'd probably put a full stop there actually. That's probably all you need in order to be part of the jabbing workforce. And the bureaucratic process that was around, particularly NHS professionals process, was really putting a lot of people off and frustrating them. But we hope that we're in a position now where NHS England and ministers understand. I understand that only about an hour ago in Parliament, Secretary of State made it clear that he was strongly in favour and would be implementing a light touch approach for clinicians to get back into the workforce. So I think we're there, and I think there's tens of thousands of people out there who want to contribute voluntarily or maybe in a paid role to allow us to not only deliver the vaccine effectively, but also do what we've already discussed, which is carry on delivering business as usual. Because, you know, one of the threats, one of the concerns for me is in a month's time, we're making great progress delivering the vaccine, and all of a sudden we're being told you're missing diagnosis of cancer, you're not diagnosing children against, you're not immunizing children against measles, you're not looking after people with unstable long-term conditions. We have to be able to do that as well. So that's where we need the vaccination workforce to free up the established workforce to do business as usual.
Brilliant, thank you, Martin. And in a minute, I'm going to come to Anthony, as you suggested, around prioritisation and the changes in the second dose regime. But we have had a question on YouTube from Terry, who's saying that should returner GPs work with GP practices rather than other NHS sites? He's a GP returner working for the 111 CCAS service at the moment, but is this an opportunity to demonstrate the better efficiency, effectiveness of general practice? Perhaps, Mark, I can throw that one at you for a brief comment.
Well, thanks, Gary. Well, look, I would just encourage Terry and people like him to come back into the workforce. I wouldn't go so far as to say it doesn't matter where you go. I mean, clearly it does. You know, we need people to work, you know, in the roles that will deliver the greatest the greatest care and the greatest effect to our patients. If Terry is already working with 111 and with CCAS, then he is already making an absolutely enormous contribution to the effort that is being made at the moment. I think as we move forward, you know, it is going to be important that the bulk of vaccinating doesn't fall to GPs and nurses. That is a pretty scarce resource that we have, and even with returners, it is going to be so. We hope that as we move forward and the AstraZeneca vaccines protocols and PGDs and so on become available, that we are going to be able to use healthcare support workers in vaccinating roles, and that will free up registered healthcare professionals, nurses and GPs and so on, to perform those other vital parts of the system that Martin's just been talking about, in terms of, you know, keeping people who don't have COVID well, and making sure that we address their health needs also. So I think I wouldn't encourage Terry to ditch CCAS and to move into just vaccinating. I would encourage him to do to work in the way that that he thinks is most effective. But we just need to get these people back into the work pool, as Martin has already set out.
Brilliant, thank you, Mark. And we've had a couple of questions on Twitter and Instagram talking about the change in guidelines to vaccinate more people and to delay the second dose, and some questions related to that around the supply chain. The supply chain is really up to sort of NHS England, so I'm going to park that bit of it. But I would, Anthony, like to ask you about the role of the JCVI in that change in guidance, and why that came about. What's the benefit of delaying the second dose?
Well, thanks, Gary. So that we have two vaccines which are approved for use, the Pfizer vaccine and the AstraZeneca vaccine. Can I just start with the AstraZeneca one first? Many of your listeners will have heard about the low dose, standard dose being more effective. And we looked at that data, as did the University of Oxford, who conducted the trial. It became quite apparent that the low dose regime actually had a quite a significantly delayed second dose, and that's why the efficacy data was so much higher. So then we looked at the Pfizer data really carefully, and the Pfizer data, they were given the vaccine at baseline and at 3 weeks. But of course, and they quoted a 53% effectiveness after the first dose with a 94% effectiveness after the second dose. But when you looked at that 53% figure, that included many cases that occurred over the first few days that the vaccine had been given, way too quickly for immunity to develop. And the presumption is that some of those vaccinees had COVID at the time or developed it shortly afterwards. When you took out those cohort that had been vaccinated between 0 and 14 days and looked at the figure of the vaccinees that had received vaccine after between 14 and 21 days, you get to about an 89 to 90% efficacy figure. Now, we know from other vaccines that the immunity from the first dose of vaccine doesn't suddenly drop off a cliff after 3 weeks. And we know from the AstraZeneca data that the immunity seems to be better if you give a delayed second dose. So we decided, given the current urgency of the situation, that it was far, far better to immunize more people with 1 dose than fewer people with 2 doses. If you look at the epidemiology at the moment, our calculations are that if you immunize 1 million extra people with that first dose as opposed to giving them the second dose, you will save between 3,000 and 4,000 lives in the over 80 age group, where the hospitalizations and deaths is much higher. So when you look at this as a national policy, it becomes really clear that that is the best thing to do. However, we don't know fully when that immunity is going to drop off, which is why we said at JCVI and the MHRA agreed and said that we do expect this is still a 2-dose strategy, and the second dose for the Pfizer one can be given any time between 3 and 12 weeks, and the second dose of the AstraZeneca one between 4 and 12 weeks. So we're fully expecting everybody to have a second dose, but just to re-emphasize, it's a much clearer national strategy to delay that second dose. And in fact, if you work from the AstraZeneca data, it might actually be better to delay the second dose. So you may get better longer term immunity if you delay the second dose. And can I just say one other thing, Gary? This isn't just sort of plucked out of thin air. This is really careful examination of the data. And when we look at other vaccines, and many of your members will be familiar with the HPV vaccine story. It started with a 3-dose strategy. The trials were on 3 doses, but actually when you look at the data, we went down to 2 doses, and we are shortly going to go down to 1 dose. So there's a lot of precedence for this. Nasal influenza in children was licensed initially for 2 doses. We know that 1 dose is effective. So actually a 1-dose strategy it isn't unheard of in other vaccine fields. However, we're not recommending that at the moment because we just don't know the data. So we are recommending a 2-dose strategy for this, but it may be that 1 dose gives you good protection. And we estimate that it will give you good protection. So we think it's a safe, effective thing to do. And from a population point of view, it makes huge sense. And, you know, we are all in the business in primary care of making a difference. And when we think about the sort of the numbers needed to vaccinate to prevent 3 or 4 deaths, this far outweighs the number needed to treat, for instance, with you know, blood pressure treatment or lipid lowering therapy. I mean, this is a different scale of impact that we're going to have in primary care. So that's why we made the decision, Gary.
Excellent. Thank you very much. I'd like to ask another question around prioritisation, if I may, because it's something that we've had a few questions come in on. And that's basically throughout the COVID pandemic, it's really shone the spotlight on inequalities. We've seen the Institute of Fiscal Studies publish an update to their Deaton review, which suggested that, just checking the figures, yeah, that mortality rates from COVID-19 were twice as high in the most deprived areas of the country than in the least deprived. And not only that, but we've also seen a difference from the ethnic minority backgrounds of people that have been impacted by COVID-19. You know, sadly, 14 of the 16 GP colleagues that have lost their lives through the pandemic were from BAME backgrounds. Now, we at the RCGP, and Martin might like to comment on this in a moment, wrote to the JCVI about the prioritisation of different groups in the workforce. And I wondered if you could just tell us, perhaps Martin, if you could explain the letter, and then Anthony, your response, please.
Yeah, thanks, Gary. This is a really important issue. So as a college, we accepted the JCVI prioritisation list on the basis of the evidence that they presented to us, that age is the most important risk factor, but also on the basis of the practicalities. It's an easy thing to identify, it's an easy thing to get on and actually vaccinate people with. Having said that, you know, we are very sensitized as a college, and I know everybody is, to inequalities, particularly around our Black, Asian and minority ethnic populations, but also others, you know, poverty, you know, somebody who's got a risk age of 50, you know, might well have a risk age of 15 years older if they're in poverty or discriminated against in any way. So we've been raising these questions, asking questions in a legitimately open way, particularly around Black, Asian and minority ethnic. And we wrote a letter to the JVCI, and they, I have to say, received it extremely positively and gave us a response, which I'm going to pass over to Anthony to describe.
Yeah, no, I mean, the college raised a really important point, and JCVI were very conscious that the BME community, you know, as Martin says, the socially deprived population were hardest hit by this, by COVID. And so we carefully, because we are a data-driven committee, and we carefully looked at the data to see whether we could unpick what was going on. It becomes quite apparent from looking at the data that there are many confounding factors in the reason that BME community members are disproportionately affected, around comorbidities, around household crowding, around social deprivation, a number of other factors. And when we looked at it in real detail and took out those confounding factors, it's not clear, though we don't absolutely know this yet, that ethnicity per se is a risk factor. We think it's confounded by many other factors. However, we don't know that. And so what we decided on JCVI was to come up with our priority groups based on what we definitely knew were risk factors. But we encourage everybody to reach out to ethnic minority groups and reach out to socially deprived groups within those priority groups as they, so it would be quite appropriate if primary care were to decide that, you know, once we get down to the, for instance, the 75, this is just an example, 75 to 80-year-old group, to reach out to those deprived populations and those ethnic minority populations first within those groups. The other thing that which probably isn't talked about a lot, but we we were quite conscious of stigmatization, and we certainly didn't want to stigmatize certain groups as being particularly COVID carriers, if you like. And we were very worried, as there has been lots of reports in the States, for instance, of Chinese ethnic groups being stigmatized immediately following the virus. So we were very keen that we didn't do that. So looking at the data, just to summarize, there isn't strong evidence that ethnicity on its own is a risk factor. We're not certain yet, but we do want these groups to be prioritized within the priority groups that we've outlined. And I think that the RCGP's letter on this was very helpful and created lots of debate and discussion and revision of the examination of the data. And so that's our view.
Brilliant. Thank you both. That was a really clear explanation of how we've got there. But it seems on the back of that the NHS and these services do have a duty to reach out to these communities. So perhaps I could ask Helen and Ravi, you know, as nurses, as pharmacists, very trusted members of our team, really important in motivating patients in all sorts of aspects of looking after their health. What can your colleagues do, and what can other colleagues in primary care do to reach out to these groups? Perhaps I'll go to Helen first, please.
Thanks, Gary. And yes, I think it's really important, isn't it? Because I think, again, when you look at a practice population, you will often have very good understanding of where the particular groups, where the particular vulnerable groups are within that population. And I think as with any vaccine program, to be fair, it's really important that you target messages and you make the services available to those groups in a way that people can access, whether it's language barriers, whether it's getting to and from the surgery, whether it's getting to and from the appointments, whether it's having that confidence and trust in the healthcare professionals who are giving the vaccines. And I think what's quite interesting is we don't really know whether ethnicity itself is a factor with, what's called vaccine hesitancy. There's been a lot of discussion as to whether it might be, and there's some work going on through. I know London School of Hygiene and Tropical Medicine are doing some work on this. So I think it's important that we do better understand. But what we do know from all of the evidence is that it's really important that you target the population that you're serving and that you make the vaccine, and in this case, the COVID vaccine, accessible to those people, and you're able to answer the concerns. So, when we think about the flu vaccine and the live attenuated vaccine for children, we know that the Muslim community particularly had very real concerns about the porcine element. Well, we know that this vaccine doesn't contain porcine, but there may be other things that come through within certain groups of the population that we need to be able to address. But it's about talking to those people and addressing the fears as they come in. You can't sort of blanket approach with information. And I think that is also beginning to come through. So I think from my point of view, I often sort of say to colleagues, understanding their population and being able to drive that forward with what they know about their particular group of people and their patients.
Okay, brilliant. Thank you, Helen. Ravi, do you want to add anything to that, or do you want me to ask you a slightly different question?
It depends what that different question might be, Gary. I suppose I just just to add that just slightly, just because being a pharmacist and coming associated from someone from a Black, Asian, minority ethnic background, I think I can probably speak a bit more confidently about some of the barriers that people have been experiencing on the front line, including my nan, for instance. So one would think that workforce diversity is incredibly powerful. Across pharmacy, nursing, general practice, there is such a high proportionality of healthcare professionals from a Black, Asian, minority ethnic group, and a number of other protected characteristics. How you empower local leadership regional leadership in service to design and agility is fundamental of how you will reach out to some of those populations, whether it be myth busting from a WhatsApp group that my nan has got about turmeric saving COVID, or whether it be around reassuring people there are communication barriers around language difficulties, understanding the risks of a COVID vaccination, understanding the benefits of having a vaccination, when there's lots of unfortunate incorrect news within the public domain, I don't think is also very helpful. I think the workforce itself should be empowered to help with service design, being mindful of the population that they're serving. I would also say that nationally there needs to be a proper public health campaign around supporting people in vulnerable and at-risk groups. And I think work at NHS England is happening quite around that at the current moment in time. And I would lastly just say outreach work and community pharmacy, again, social deprivation areas, hard to reach populations, a fundamental role. They've done it for many years, decades now. Empower that workforce to help you deliver some of those really hard to reach areas would be another one recommendation I would suggest going forward.
Brilliant. Thank you, Ravi. And that was a great answer, but it does mean, unfortunately, you'll never know what the other question was going to be. Again, we talked about the Instagram polls we ran earlier, and we asked, are we doing enough to prioritise vulnerable patients for vaccination? And the result we got there was 40% yes and 60% no. So still a work in progress, still stuff to do. And thank you for the suggestions to Helen and Ravi that you've just made. The other thing I want to touch on is people never think they've had enough communication about whatever subject it is. And again, one of the other polls we ran today was asking people if they thought general practice was getting enough information down from NHSE and from the government about the vaccination programme, and only 9% of people had said yes. Now, that reveals a huge information gap there. And I just wonder, perhaps, Mark, you'd like to come in on this one. What more can we do in order to get that sort of information out there, to get people confident and competent to be delivering this programme widely and at speed and at scale as we need to?
Yeah, well, I think we need to do more, Gary. It's as simple as that. I mean, I would come back to the point I made earlier, which is about the phenomenal pace at which this is happening. I was asked earlier today if I could do a written report for a meeting that I can't make next week, and my response was I can, but almost by the time you've written the report, the facts have changed before the ink's dried, and that is a part of the problem with what we're dealing with at the moment. Things are changing so rapidly, but look, we just have to do better. I think that it will naturally, things will start to bed in as we get a little bit more stability in the system, and the turnover of advice becomes less frantic. But we just have to get as much information out there as we can for people, because that's the only way that they can make reasoned decisions about how to provide these vital services in their localities.
Brilliant, thank you, Mark. So as ever, it comes down to trusting professionals, but giving them enough information to allow them to come up with sensible solutions. We're coming towards the end of time. I'm going to allow us to run a couple of minutes over, because there are another couple of areas I really want to touch on that I think are really important. I think one of the big challenges we've had in general practice across the pandemic is because we've been having to work in different ways. Whenever we do any media work, we're always getting the question or the comment, it's nigh on impossible to see a GP. And we know that's not the case. We know general practice has been open. Martin, you've done a huge amount of media work defending the profession and explaining the different ways we're working. I just wonder if you'd like to say something about that as we come towards the end of this session, please.
Yeah, thank you, Gary. This is so important, isn't it? Because I understand from a patient perspective, they had an established system of general practice. They knew how to access it. By and large, they liked it. We know that. We're really high trust ratings. So when a system completely changes in the way that we deliver care, in the way that it had to, as a consequence of the need for good infection control, of course, it's going to take a long time for patients, but actually also for clinicians to get used to it as well. So the way that we shifted from 80% or so face-to-face consultations, to, at the height of the crisis in the spring, only 10% face-to-face. Now the data that the college collects suggests it's on average around about 44-45% of consultations are face-to-face. You know, that is a difficult thing for people to get used to, but we've managed to keep the service running. And we found out that actually technology is very useful. We found out that there is quite a bit of what we do in general practice that can be done remotely. We've also, I think, reminded ourselves how important face-to-face contact is in terms of building relationships. So I think what general practice is doing is trying to get the right balance between face-to-face and remote consultations, trying to meet patients' needs as effectively as it possibly can. I was struck by a conversation I had with a colleague who works with in an extremely well-run, experienced general practice in the Midlands. He introduced a system of electronic triage and more remote consultations about 3 years ago, well ahead of the game. And he said that it took him about 2 years, even when they planned well, and even when they were really well organized, it took about 2 years for patients and clinicians to really get used to it and to get it working really well. And general practice did the whole of that process in a matter of weeks back in the spring. So it will take time to settle down, but actually we're open for business, different kind of business, but we're open for business. And it's really important that patients hear that message.
Brilliant. Thank you, Martin. So we are coming to a close. I like to end these discussions with literally 30 seconds each. I'm going to be quite strict about the timing on this one. Just one thing you'd like to see change to allow us to achieve our aims of not just rolling out this vaccination programme, but allowing us to do all the other things that are so important that primary care does. So if I could start, please, with Helen.
Right. Well, I mean, I think the message for me is that we just need to be mindful that this is a growing programme, and that inevitably it will bed down, as people have said, and we will get, you know, the information will come through. And I think for colleagues to be a bit patient in terms of how that information comes through. So I think that's my overriding message, and just remember that it's a multidisciplinary impact. Brilliant.
Thank you, Ravi.
I just agree with some of Helen's points. Actually, it's a multidisciplinary team effort. I do think it will be a long race, as Mark just probably said. 100 million vaccinations is likely to be the total. It will take months to do that. Being inclusive in delivery would be something else I would vouch for, looking at how we increase capacity across the entirety of primary care, looking beyond general practice as an also useful resource to support the vaccination programs from government and the NHS, and asking pharmacy colleagues and teams to see how they can support your delivery, particularly with those hard to reach and vulnerable populations, is another ask I would ask for. Thank you.
Brilliant. Thank you, Ravi. Mark.
Yeah. Right, so sorry, I thought I was on mute for a second there, Gary. I do apologise. Well, certainly we need clarity to GPs and to patients about what routine GP services may need to be suspended during this campaign. We need certainty around the supply of vaccines and delivery dates. We need unequivocal administration protocols so that we can plan our workforce and our delivery systems. We need sympathetic leadership from NHSE to allow local flexibility, and we need stability of approach to allow that proper planning. We need a mass information campaign to the public, and we need to get rid of this red tape that's preventing some of these people coming back into the workforce that we need. And finally, and most importantly of all, the system needs to trust GPs to do what we and our teams do best, which is deliver mass vaccination campaigns.
Brilliant. Thank you, Mark. Anthony, please.
Yeah, I just want to say this is the most important prevention you will ever deliver in your careers. And you will look back on this when you've achieved this mass vaccination program. You'll look back on this and be very, very proud of everything you've done. I had patients crying with gratitude when we were immunizing them. And whatever our short-term difficulties will be, we will get through this together. And I think we, as a primary healthcare team and society, and I include all the professionals in that, will really, really shine like beacons at the end of this. So we have an opportunity here to make ourselves really, really stand up in the public's eye. So please, please go ahead, show leadership, have a can-do attitude, and let's get this done.
Brilliant. Thank you, Anthony. That's a really, really important message. And finally, Martin.
We need pride and we need celebration. We need pride in what we have achieved. We need to celebrate what we have achieved. We need to recognise that we are doing a truly remarkable job across general practice for our local communities. We should be really pleased with where we are, and we need to maintain that sense of kind of excitement over the next 6 months, which are going to be really, really tough for everybody. And if we don't look after ourselves and look after our colleagues, we're not going to be able to achieve what we need to achieve in the next 6 months.
Brilliant. Thank you all. Thank you to everybody that's watched this evening. You'll be able to watch on YouTube immediately after this. Thank you for those that have contributed questions. Thank you to everybody out there right across the primary care team for everything you're doing for our patients at the moment. We'll be back with another RCGP Live on the 21st of January. No smaller topic next time, the topic of Brexit and the impact that might have on healthcare. But thank you again to everybody on the panel. Thank you to everybody for watching. Enjoy the rest of your evenings and take good care. Good night.